multi-purpose cache, because it's quite a big component of the response in Nigeria. And closely related to that is actually the minimum expenditure basket and transfer value. And I did a small analysis there as well. And then the last part is looking at the recommendations that were mentioned in the report. But I'm also quite flexible, so it really also depends on the requirement of the group and whether you would like to talk or whether you would like me to talk about something in addition. Please let me know. I would actually, I don't see who is on that call, so I would appreciate if we could make a short round of introductions now so that I know who is listening in. And I think maybe Seven, we can do that by everybody raising their hand and then you allowing them quickly to introduce themselves.
Okay, thank you. Yeah, I will do that. If they can raise their hand, at the moment, we'll allow everybody to speak and then we'll introduce. So we can start with Abidemi.
Hello, good afternoon, everyone. I'm Dr. Abidemi from TDH. Can you hear me?
Yes, we can.
We can hear you loud and clear. Thank you, Abidemi.
Okay.
Okay. Good afternoon, everyone.
Yes, go ahead.
Okay, this is Edem of Green Code, but I'm not just the only one here. I'm here with my team, 4 of us. I'm here as Edem. Abubakar is here as the project manager for nutrition. Mary is here as the nutrition officer, and also Alex as also a nutrition officer.
Thank you, Adam. Eddie?
Okay, good afternoon, everybody. My name is Eddie Esizobo from COPI. I'm the project manager for security and livelihoods and also for nutrition. And I'm here with my colleague, the nutrition officer from COPI in Yobe State. Thank you.
Thank you, Eddie. Jolene?
Hi, my name is Jolene Mullins. I'm with International Medical Corps here in Borno State. Thank you.
Thank you, Jolene. Adeza?
Good afternoon, everybody. I'm Dr. Adeze. I work with Save the Children International as a senior nutrition advisor.
Lexington?
Hi, everybody. My name is Lexington Matonodze. I'm the Cash Working Group Technical Core Lead.
Thank you, Lexington. We have Abba.
Yes, good afternoon, everybody. My name is Abba Yusuf. I work with Grow Strong Foundation and also a member for the Cash Collaborative Cash Delivery Network in Northeast Nigeria. Thank you.
Thank you. Next is Carrie.
It's Carrie Morrison, Head of Nutrition, WFP Nigeria.
Olanike.
Yeah, good afternoon, everyone. My name is Olanike Olasukomi from CARE International Nutrition Officer. Thank you.
Thank you. Cedric. Cedric.
Good afternoon, everyone. My name is Cedric. I'm with Danish Refugee Council.
Thank you. Welcome, Cedric. We have Olenka Chuku. Erin. Jeremiah.
Yes, good afternoon, everyone. It's Jeremiah from International Committee of the Red Cross.
Welcome. Karina.
Good afternoon. My name is Karina. I'm the head of nutrition for Save the Children based in Abuja.
And Tom.
Yes, good morning, everyone. Tom Solomon, USAID, Nigeria.
Thompson. So if there's anybody who else who has not introduced him or herself, please go ahead. I have unmuted everyone. Maybe the remainder of the persons who have they can introduce themselves on the chat, so that we can continue with our presentation. Please just kindly requesting, if you have not introduced yourself, to introduce yourself on the chat, so we will be able to, for the benefit of everyone. So maybe I'll give the floor back to Andre.
Great, thank you very much, Simon, and great to have such a diverse group of people online. So maybe just one word on my role, one additional word. My main task as part of the work with the Global Nutrition Cluster is to develop guidance on the use of cash and vouchers for nutrition outcomes. What I'm going to present here is basically this, or at least in the first part, is basically the latest state of my work in terms of the frameworks. I think somebody has his mic on, maybe Simon, can you unmute? Or somebody else? Some of the things that I'm going to say doesn't 100% ground itself in the evidence base, because sometimes the evidence base for some elements of using cash and vouchers for nutrition outcomes is not very strong. I have, however, a reference group of about 20 people from different organizations, mostly nutritionists, that basically provide feedback to my work. So they are also the ones that are validating what I am kind of proposing as a conceptual frameworks for how to use cash and vouchers for nutrition. Maybe just as an introductory remark. Somebody is making a lot of noise, and I would really appreciate if everybody could mute themselves. Thank you, much better. Great, so these are the three main parts of today, and we'll better get going. So Simon, please, next slide. Yes, you can actually, yes, next one as well. One more. Yes, thank you. So from the introductions, I saw that most people are actually have a nutrition or at least a food security background. So I take just the opportunity to give a very short introduction into the terminology for cash and voucher assistance, because I think there's still a lot of confusion around some of the concepts. Yeah. So CVA, cash and voucher assistance, we also call it, or we used to call it, cash transfer programming, or cash-based interventions, or cash-based transfers, depending on which organizations you work for. But essentially, it's the provision of cash or vouchers, so two distinct modalities to targeted recipients. And recipients can be individuals, can be households, or can also rarely be communities, to access goods and services, to address specific needs. Now, in the context of nutrition, there's certain things that you might consider to be CVA, but they're actually not. And I think it's important to distinguish here. For example, the payments. Yes, I hope you can still hear me. Otherwise, please let me know. So what is not CVA? For example, the payments of incentives of volunteers or of community health workers. We don't consider CVA because these are not our targeted beneficiaries. Same goes for payments to institutions. So, for example, a transfer of money to a school for a school feeding program would not be considered CVA. Transfer of money to a health center would not be considered CVA. Transfer of money to government institutions certainly would not be considered CVA. So this is just important to understand what we mean if we say CVA. First important distinction here is making a distinction between sector-specific CVA and basic needs CVA. Yeah? Because the multi-purpose cash transfers, which a lot of people talk about, that's really grounded in basic needs and is supposed to cover needs across different sectors. So, for example, food security and nutrition, shelter, water and sanitation, health, etc. So there, the objective is specifically to cover objectives across different sectors and clusters, while there's also design possibilities to do sector-specific CVA, which is really grounded then in one sector, and that's primarily a design question. Then, in terms of conditionality, we distinguish between unconditional and conditional. And conditionality basically means what the recipient has to do in order to receive the assistance. It's not necessarily tied to cash only or to vouchers only. It's also supposed to be food, obviously. It has nothing to do with how the money then later will be spent. That's there we talk about restriction, and I think the two concepts are often still confused. So when we talk about nutrition programs and the conditionalities that can be applied to nutrition programs, they are usually either participation in social and behavioral change communication sessions, face-to-face usually, or they're related to the attendance to health services. Yeah, health services, primarily the preventative ones that we know have an important impact on child and maternal nutrition. So these are the two primarily conditionalities that you can apply. Cash for work is probably the most common one in the humanitarian sector in general, but not necessarily one I would recommend for nutrition programs. By the way, if you have any questions, feel free to interrupt, yeah, because I think we're still a small enough group to not have to wait until the end. So if you have any urgent questions, please interrupt. Otherwise, we can also take it following the presentations of each part. Yeah. Simon, next slide, please. You can just click through here. One more. Yes. So in regards to utilization, we distinguish between unrestricted and restricted. And very simply speaking, unrestricted means cash, because once you give money, people will make their own decisions on what to buy. And you can, of course, try to influence that decision-making by labeling it. So, for example, giving money and saying, so this is for food, or this is for rent, which, you know, can have a little impact. Or you can also, of course, like we said before, couple cash with social and behavioral change, and that's probably a more sustainable way in influencing how families or individuals spend cash and voucher assistance. Restricted is basically means vouchers in CVA, but of course in-kind is also restricted. And the restriction with vouchers comes with so a voucher you can only redeem at certain shops that are contracted by the implementing organization. So you cannot go anywhere with a voucher, but you have to go to specific shops. And you can also limit what people can buy with that voucher. So you can, for example, a fresh food voucher, something very common in nutrition programs, can only be used for fresh foods. And there again, you have two design options. You can either go for commodity vouchers or for value vouchers. Commodity vouchers are essentially, you exchange a voucher against a predefined ration. Yeah. So no choice. It's a bit like in-kind, but you pick up the ration in the local shop, and of course you might have access to a bit more localized food items. But essentially you don't have any choice. Value vouchers, on the other hand, have a monetary value, and you can use that monetary value to buy approved goods. So for example, in the fresh food vouchers, you can give access to 10 different fresh food items, and then people can basically use that value voucher to go and buy 10, according to their preference. They can shop within these 10 food items, just as an example. So that's for the modality. And then delivery mechanism, of course, we're not going to talk too much about that. You have, for cash transfers, it can be cash in hand. That can be, for example, in envelopes, can also be over the counter. So you go to a bank, you go to a trader, and you pick up the money after following your identification. And then, of course, there's all the different electronic ways you can transfer cash. Mobile money is being used in Nigeria. You have debit cards, for example, that you can use to either to pay things or to go to an ATM to collect money there, etc. So there's different options in different contexts, obviously. And with vouchers, there's two main options. You have the paper voucher and the electronic voucher. And electronic vouchers, you need a system essentially. WFP has Scope, ICF is using, I forgot the name, but there's a whole variety of different solutions, Red Rose, etc., that are out there that you can use. Good. Next slide. Good. Okay, that's fine. Okay, so here we have the conceptual framework for malnutrition, the updated one actually from UNICEF. And I think you're all familiar with that, so I'm not going to spend too much time here. But just to point out where you find the cash, yeah? So you have the little green box in the bottom where it says resources, and you have the resources at societal, at household, community, and individual level. And one of these resources is financial now. So that's basically where a cash transfer sits from the beginning. So if family receives, or if an individual receives cash, and to some extent also vouchers, that's a financial asset that then later can be used for different things. And cash primarily acts upon the underlying determinants or the underlying causes of malnutrition. So with cash, of course, you can buy nutritious food. You can use the cash to access health services. You can use it to improve your household health environment. You can use it to access water and sanitation items, etc. You can potentially also use it or you can use it to improve complementary feeding. It potentially also gives you more time to provide adequate care to your child because the economic pressure is lessened by cash transfer, etc. So it's really acting upon primarily the underlying determinants, and of course, then indirectly also it can influence the immediate determinants and lead to outcomes. But we'll come to that. If you click more, Simon. So when we want to know, what the contribution of cash and vouchers can be to improve nutrition or to achieve nutrition outcomes, what is a good entry point is actually looking at the different barriers to adequate food, so the barriers to the underlying determinants, so barriers to adequate food, barriers to adequate feeding and care, and barriers to a healthy environment. And we'll look at that in the next slide. So the key message here is cash and vouchers can help to directly address the underlying determinants of malnutrition, largely, of course, depending on household decision making, especially with cash, but also with value vouchers, where you have quite a big flexibility in terms of what you can use the money for. There is, of course, different pathways that will follow that decision making. Next slide. So here, I hope that's not too overwhelming, but I think these slides can also be shared following the presentation if you want to look up some things. But here, essentially, you have demand and supply side barriers to the different underlying determinants or causes, depending on how you look at it. Yeah, and this is probably not a complete list, so I'm sure we could find more here, but still it includes quite a lot of items, and I'm not going to go in detail into all of them, but you can see here that some of them are, especially on the demand side, are marked in yellow, and these we can consider as the economic barriers to adequate nutrition. Yeah, so economic barrier basically includes if a household or an individual does not have the money in order to do certain things, to access goods and services, or it can also be related to opportunity costs. So, for example, a family that has a malnourished child and is now considering to go and receive treatment services for that child, it has to accompany that child, it has to pay for transportation, it might have to pay for other things, and it will not be able to follow its usual livelihood strategies, or be it working in field or daily labor or whatever it is. So there's also a loss of income associated to that we can consider as opportunity costs. So looking at that, looking briefly at the yellow ones, obviously, one important one is that nutritious foods are not affordable to the family. I think that's very often the case for the most vulnerable parts of the population. We all know also, or you as nutritionists know, that a nutritious diet is considerably more expensive than a diet that is focusing on the calorie requirements of individuals and households. Then, of course, transportation might not be affordable if people cannot walk to markets. Then on feeding and care, again, nutrition-dense complementary food are not affordable, and lack of caregivers' time for optimal feeding and care due to other priorities, for example, work. Then on the health side, we have health services are not affordable due to out-of-pocket expenses related, for example, to consultation, medication, food and accommodation during hospitalization. So especially for inpatient care for children that are suffering from SAM, often caregivers have to stay with the child, and that there's certain costs associated with that as well. Transportation to health services is not affordable. The opportunity cost of seeking health and nutrition services are considered too high. We already talked about that. And then, of course, you also have certain hygiene items for general and specific needs that might not be affordable, or safe water can, in certain contexts, also be purchased. That might not be affordable, or water treatment might not be affordable. So there's a whole range of economic barriers, primarily on the demand side, that could potentially be addressed with a cash and voucher approach. Now, please note here that the supply side, there's no yellow, meaning that, CVA primarily works on the demand side. So that also means that if the supply side is not properly working, so if you don't have the foods, the right market, if you don't have the right health treatment services for the prevention and treatment of malnutrition, etc., then you're not really going to achieve anything with providing people money in order to stimulate the demand side. So the supply side, obviously, it's very important. Now, there's certain things you can do with a voucher, like, for example, when it comes to availability of foods, if you use a voucher approach, you can also, of course, have discussions with traders in order to explain, how much the expected additional demand will be, and encourage them to bring in these foods, etc. So there is certain things that you can do on the supply side. And of course, if you give money to people and you will kind of boost the demand side, traders will usually react to that. So they will see that there is additional demand, there's additional purchasing power, and if they can, they will probably bring in additional goods in order to increase their profits. But again, primarily cash and vouchers work on the demand side. That doesn't mean that the supply side, the supply side is extremely important, and a lot of things can be done, including also market-based interventions to strengthen supply chains, etc. But we're not going to talk too much about that today. But it's kind of part of the broader market thinking, of which cash and vouchers, of course, is an important component of. Next slide. Good. So the main message is here. CVA can help to address demand-side economic barriers to adequate nutrition, but is less effective on the supply side. We said that. And also, what is really important, cash and voucher alone is unlikely to be a successful strategy to improve the nutritional states of children. So you just kind of visualize the demand and supply side barriers. And of course, if the main barriers are really on the demand side and are related to economic barriers, then yes, by giving cash and vouchers, you have a good chance of reaching nutrition outcomes. But if you have other barriers that are important, either on the demand side, maybe related to behavioral aspects, or on the supply side, then cash and voucher alone will not be a sufficient strategy to improve nutrition. So that's why, in principle, I should be combined with other nutrition sensitive and specific interventions. But we'll come to that. Next slide. Next key message is cash and vouchers can complement or substitute traditional nutrition response options. Yeah? And we will look at that in the next 3 slides by looking first at by looking at some of the nutrition response options, the traditional response modalities used. So that's the second column, and the possible role for CVA. So sometimes CVA has the potential to replace, sometimes or in most other cases, it has the potential to complement. Yeah? And then, of course, you have also the objective related to the CVA. Of course, if it's replacing the original modality,
Andre, we can't hear you. Andre?
I don't see the slides anymore. Can the others see the slides?
No, we can't see the slides too.
Sorry, my internet just dropped. Apologies, but I'm back.
Okay.
Sorry. Andre, also speak closer to your mic.
Yes.
You're a bit on the low side.
Okay, all right. Is better now?
Yeah.
Okay, great. So just that as an explanation, and here we have the nutrition center. We have just again is not comprehensive, but 2 nutrition sensitive response options: general household assistance that can largely be replaced with the cash and voucher approach, and livelihood support anyway that traditionally has been using cash grants and sometimes even vouchers as the primary modality. Yeah. Next slide. Good. So here we are now moving into nutrition-specific response options, and we're moving into prevention of malnutrition, where cash and vouchers has the biggest potential in my view. And you can see the nutrition response options on the left, starting with IYCF, which actually it's IYCF/social and behavioral change communication, because SBCC often in the nutrition setting is very IYCF focused, but you can essentially apply it to both. And the possible role of CVA there is obviously not to replace these the counseling or the communication on these topics, but of course it could be. First of all, the attendance can be made conditional, in which case the CVA can incentivize participation in these sessions. Yeah? And second of all, which is not written down here, is actually what you learn in these sessions about complementary feeding, about nutritious diets, etc., etc. The CVA can actually help you to translate some of that learning into reality. So if somebody explains to you how you actually should feed your child with complementary foods and how they should be prepared, etc., now then often households go back home and they don't have the means actually to follow up on that. And with cash and vouchers, you could actually provide some purchasing powers that allows the caregivers to implement some of these recommendations. So that's quite important. Blanket supplementary feeding and complementary feeding, there is a general consensus that cash top-ups of fresh food vouchers or food vouchers in general, representing a value or with a value that is based on the nutrient requirements of the at-risk groups, could actually replace the specialized nutritious foods that are given for preventative purposes. Yeah. Prevention of micronutrient deficiencies, there it's from the discussions I had with the reference group a bit more complicated. So there certainly the nutrition supplements, it's not really possible to replicate with local foods on the market, or it's much more difficult. So there's no recommendation, or there's actually a recommendation not to replace nutrition supplements with CVA, but potentially to complement, to allow access to a more diverse diet. Yeah. Provision of breast milk substitutes. There, I think the voucher could play a role, where the voucher could be provided to families that actually require BMS for specific reasons that have been identified, in order to obtain BMS in contracted vendors. But that's of course only relevant in maybe rather relevant in middle-income countries where you, for example, find BMS in pharmacies that are of sufficient quality. Yeah. So they're code compliant. And then for the provision of priority health services, so priority health services are the ones that are particularly relevant to prevent malnutrition. So certain vaccinations, deworming, pre and postnatal care, growth monitoring, etc. And there, CVA can be provided conditionally, as we already discussed, which can increase the uptake of these services, as the evidence seems to suggest. And of course, it can also complement. So CVA can cover costs associated with accessing these services, for example, transportation, or out-of-pocket expenditures in seeking these services. So that is certainly something that CVA can achieve. Yeah. So that's for prevention. Next, somebody has a question. Jeremiah, do you want to raise that question, or you want to keep it for later?
I guess I could raise it.
Yes, please go ahead.
Okay, my question is regarding the CVA when you add it to a social behavioral change program in terms of the IYCF.
Mm-hmm.
So my question is, at what point do you ensure sustainability? And by sustainability, I mean having to prevent the mothers or the target group coming just because they want to be eligible for this cash-based program, and at the end of it, missing out on the key objective, which is to change their behavior. And then in the event that you are not able to sustain the program for too long, for so many reasons, how do you ensure that the people continue to engage in that activity if you are going to relate it to the cash-based intervention?
Yeah. Well, I think that's probably more a question to nutritionists actually, but from my intuition tells me that if you can make the SBCC kind of interesting and engaging, and if people see value in it, then they will continue they should continue to attend these sessions. Of course, if they don't see any value in it, then then that's problematic. And then of course, if the cash is the only reason why they show up, then that's not an ideal scenario. But maybe we can talk about that point specifically when we discuss the experiences in Nigeria of coupling cash transfers and SBCC, which some organizations have quite good experiences with. So maybe we can keep that question also for later. Is that all right?
Perfect.
Okay, great. Good. Next slide. So that's still nutrition specific, and specifically now talking about treatment of malnutrition. And here, basically, cash can complement. It can certainly be an important factor in accessing health services, as we have seen before. So not only for preventative services, but cash can also help to access treatment services. covering costs of transportation, but also costs related to inpatient care, so staying there, having to stay there, etc., and out-of-pocket expenditures that might be required. I'm being told that treatment is always for free or should always be for free, but there might also be follow-up treatments that are not directly related to malnutrition or medication that might require some financial means, and there I think cash can play a role. And then the other, and I think a bit more controversial topic is the general household cash assistance that is sometimes tied to treatment of malnutrition, especially SAM treatment. We'll talk about that later. Here, I think some studies seem to suggest that CVA, if a family that is released, or a child that is released from inpatient care or from SAM treatment and goes home, the family is provided with money that allows them to improve their food security situation, it can actually enhance the treatment outcomes. Yeah. At the same time, it might incentivize families to keep or to make some of their children malnourished. We have seen that as well in certain contexts. So there is kind of both considerations that have to be weighted against each other. But we'll talk about that in more detail. Yeah. So that's really related to treatment. Here also for treatment, just to reiterate, cash and voucher assistance should not replace specialized nutritious food in the treatment of malnutrition. I think that's an unrealistic expectation of what CVA can potentially achieve. Yeah. Key messages coming out of this, and I'll go one by one. Household cash and voucher assistance plus SBCC has proven to be an effective strategy. There's quite strong scientific or peer-reviewed evidence, but also operational evidence that this is something that works well. The two seem to be mutually reinforcing each other. Like I said before, the SBCC around IYCF and nutrition, often in order to implement some of the advice and the learning, actually financial means are required. So with the cash, you can actually help to implement some of these lessons. SBCC itself can help to improve the kind of the spending, or can improve the chances that families spend or individuals spend the cash or the voucher in a nutrition kind of centered way, or in a child-centered way. Yeah. So there's quite good evidence coming out there, and that's why the guidance is really for, if organizations use especially cash, because there you have the biggest flexibility as a recipient. If organizations provide cash for nutrition outcomes, so if you want to achieve nutrition outcomes with your cash, you should always have an SBCC component. Yeah. Second key message: household assistance plus individual feeding. So especially from the food side, often the individual feeding is backed up by household assistance. So the blanket supplementary feeding is actually backed up by GFT, for example. Now, we've seen that for prevention, both of these components can actually, or both household assistance as well as individual assistance can be implemented through a CVA approach. Yeah. What we are seeing coming out from some studies is that certainly for the household component, it's really context specific which modality works better for food security and nutrition. Some studies seem to suggest that CVA might actually be better because it gives more flexibility, and it allows households to do things that are just not possible with an in-kind approach. However, for the individual assistance component, so individual feeding, limited evidence seems to suggest that the specialized food might actually be more adequate for individual feeding. We don't have a lot of studies there, but it also intuitively makes sense because the specialized food is really designed to be nutrition dense, to specifically address the needs of specific at-risk groups, while cash and vouchers relies on nutrition dense food in the local market. So there's You probably don't achieve the same nutrition density, and then of course it's again related to decision making within the household. So specialized food might actually be better for individual feeding. And a formula that has proven to work well in one specific study from Niger is actually pairing household cash assistance with specialized food. But again, limited. We have limited evidence there, and very limited operational evidence on that approach. We have, although, quite good operational experience with fresh food vouchers. So fresh food vouchers are also often given as individual feeding, and are topped up either often actually by an in-kind ration, but it can also be kind of based or can be complemented at the household level with cash transfers. Good. CVA can potentially replace some specialized food, nutritious foods in preventative strategies if nutritious diet can be accessed in local markets. Yeah. So of course, we haven't really spoken about feasibility of CVA, but the markets are really key. And understanding what is available in the local markets in terms of nutritious foods, and how a nutritious diet actually should be composed and how much that costs is actually quite important for decision making in regards to CVA and nutrition. And there we have some good tools that are largely underused in a humanitarian context. I'm thinking particularly about the cost of the diet tool that is really provides a very good entry point in for CVA for nutrition outcomes. CVA should not be used to replace micronutrient supplements, and it should not be used to replace specialized nutritious foods in treatment strategies. We already saw that. CVA, conditional attendance to health services, can increase uptake of priority health services. So there's quite a lot of good evidence mainly from development settings, but increasingly also from humanitarian settings, and also quite a lot of good examples coming out from Nigeria. And then last but not least, provide CVA for caregivers of SAM children once they have been released from treatment. Can increase treatment outcomes, but is likely to lead to perverse incentives, which can be partially mitigated. We can go into that if you want later. But importantly, the degree of the problem is not well understood. So this perverse incentive of keeping your children malnourished in order to get the cash assistance, that there is anecdotal evidence for that. So coming from informal monitoring from different organizations I've spoken to, but the degree is not well understood. So is it 1 out of 100 children, or is it 40 out of 100? So that's really not well understood. And there's a considerable gap there in really understanding the risk. Yeah, good. Next slide. Good. So that's the end of part 1. I think, go back. I think that was quite dense. I hope you were able to follow what I'm trying to convey. Go back, Simon. But I just want to open quickly the floor if there's any questions in regards to these key frameworks or messages that were presented in the last 40 minutes. Or if it makes sense to you even, or if you feel that some of the content is not, and it does not match your experiences. Well, I take silence for clarity or complete confusion, I'm not sure. Maybe just a quick round. Were you able to follow me? Can you just shout in yes or no so that I know whether I'm making sense here? Or quickly write into the comment box. I see a yes, that's good. Other yeses, no. Some no's, all yes. Okay. Good. Okay, so let's continue. And as before, if you have any questions, make sure to interrupt me. So coming to Nigeria. So I spoke to many or some of you in regards to the projects that you have implemented in the past, and this is the list of projects that I reviewed. Is not meant to be a comprehensive list of what has happened in Nigeria over the last couple of years. It's basically what was shared with me. So I wasn't I was only able to review what I had on my desk. And I understand that, of course, not being able to physically go to Nigeria did not necessarily help, but still, I think there's a couple of interesting projects that I was able to look at. And this is basically the list. So there's a bit of action against hunger, there's a bit of ICRC, and then there is the consortium that was doing these integrated nutrition responses in different shapes and forms since 2016. And we'll talk about that. So when looking at these interventions and trying to cluster them according to the approach, it's basically three things or three approaches that were used. One was providing cash transfers coupled with SBCC. Second was having a cash transfer conditional on attendance to priority health services. And this was usually done as part of a larger nutrition response with additional interventions as well, but the cash component was a conditional cash or a cash transfer conditional on the attendance of priority health services. And the third one, there's actually only one example, and it's a bit old already, but it's provision of general household cash assistance to caregivers who access SAM treatment. Yeah, so what we discussed before. We'll go through each of them in the following slides. So starting with cash transfers coupled with SBCC. So there it's mainly action against hunger examples I received, and specifically to interventions in Yobe and Borno, not Borne, but Borno states, where the household assistance compromised the food, cash, or voucher, depending on the context and whether a cash or a voucher process was actually feasible, depending on market capacity and service provider capacity, etc. So the household assistance was provided in these three modalities to food insecure households, and for the cash and voucher component, actually the transfer amount was between 17 and about 20,000 naira per household per month. And this was coupled with behavioral change interventions targeting specifically PLWs. So not all households were targeted by that, but specifically households that had a pregnant or lactating woman. Now, the BCC component in Yobe State was done through care groups. Yeah? And if somebody from ACF is on the phone, feel free to later on talk a bit more detail what that contained. And in Borno State, it was a bit different. It was a porridge mom group approach, which actually included daily cooking demonstrations. And interestingly, it also included voucher transfers to the porridge mom group committee. So a porridge mom group consists of about 15 PLWs, and there is a committee, and I think even somebody that looks after finances. And these committees, they were supported with vouchers to buy the foods for these cooking demonstrations, and also actually with a small cash amount, as far as I understood, to cover additional costs related, for example, to the food preparation. So this is actually the only example I've ever seen of a CVA assistance at community level, where it wasn't provided to the household or to the individual. Yeah. So quite a specific approach, but quite an interesting one as well. Here we saw quite positive results and high satisfaction of the participants, so the PLWs. But we also saw that the kitchen-based activities, so the daily preparations of the nutritious meals, they were not sustainable. So they were stopped with the end of the project. Probably because there was no more money to go and buy the food, and so activities were stopped. So it wasn't considered sustainable, and ACF actually changed its approach and then changed to a more individual approach. So the vouchers were provided directly to PLWs in a later stage of that response. And it was 5,000 naira provided, calculated on the nutritional requirements of PLWs and local food prices. And cooking demonstrations were reduced to once per week, and the PLWs were actually meant to contribute to these cooking demonstrations with also with the support of the voucher that they received. Yeah. That's the experiences of Action Against Hunger, at least the way that I understood them. Now, yeah, feel free if you're from ACF or to come in and say that, or to complement if you want. That would actually be useful. Then ICRC also had one small project that coupled these two components. It was actually an IOICF counseling response for about 350 PLWs that was done, and then the ICRC quickly realized that these PLWs they are not producing enough milk, they're not receiving a nutritious diet, so they complemented they provided cash on top of these counseling sessions in order to improve the nutrition of these PLWs. But that was a very small scale response. Next slide. Okay, so that's cash transfers conditional on health service attendance, and we're still talking about prevention here. So it's preventative health services, and you have different interventions here that had that component. So it was the INP, the Integrated Nutrition Program Plus, delivered by a consortium of Action Against Hunger, WFP, and UNICEF. Then a similar but a slightly extended approach of the same project in two areas. That was called the INP Plus Intersectoral Pilot, and then follow-up interventions led by WFP, which was called the Multi-Sectoral Program, I think. But the approaches, at least for the cash component, were quite similar, composing of a conditional cash transfer component targeting PLWs with, again, the same amount, 5,000 naira, but looking really at the first 1,000 days. So from enrollment, which usually happened at pregnancy stage, once a pregnant woman was identified, throughout the first 2 years of the child's life. So quite a long period, actually, time period for a humanitarian response, but based on the findings from the latest, or from the 2013 Lancet series, etc., the targeting based on the first 1,000 days is actually seems to be quite a good and important approach. So the condition was actually related to the initial registration at the health center. So the PLWs had to register at the health center during their pregnancy, and they would receive a first initial checkup, and then they were admitted to the program. So it was, the cash was not paid following every pre and or anti and postnatal care visit or every intervention, but it was really at the time of registration. So people had to get registered at the health center in order to be enrolled in the program. At the same time, the women were enrolled in mother-to-mother support groups for mainly IYCF counseling. And the results, broadly speaking, showed that there was a significant uptake of antenatal care visits and immunizations and improvements of dietary diversity of PLWs in children. Yeah. So that's basically, you can see there's these two outcomes are actually, one is related to the conditionality. So it's the adherence or the attendance to these health services which improved. And the other one is related to the money received by the PLW, which allowed them then to in nutritious foods and improve dietary diversity.
And Andrea,
and of course,
yes. Having some, Carrie, do you have a question?
I just have a clarification.
Yes, please.
It's Carrie from WFP. Just a clarification on the conditionality and payment, and it would be the same for IMP Plus as well as the MSP program, which continued the WFP activities. The women were received the transfer on a monthly basis. It was what we considered a soft conditionality in that they needed to be registered. They weren't paid only on registration, but they received a monthly transfer for their continued participation in antenatal care, postnatal care, immunization services for themselves, for their infant, for their child, as well as participation in the mother support groups and income generating activities that WFP supported. Over.
Okay. But just to clarify, so once they were enrolled, if they would then never again show up at the health service, would they continue to receive the cash assistance for the period of the, until the age of 2 of the child?
No, negative.
Or not? Okay, all right, yeah.
Well, they shouldn't have. They may well, but they shouldn't have.
They shouldn't have, okay, all right. Yeah, so this, just to clarify, so the soft conditionality often, when we speak about social and behavioral change communication, soft conditionality basically means if people don't show up for the SBCC sessions, you encourage them, so you monitor attendance, and people that don't show up, you encourage their attendance and you follow up, but you don't kick them out of the program immediately, which would happen if you had a hard conditionality, which basically means if you don't fulfill the conditionality, you don't get the assistance. And the similar logic you can apply to health service attendance as well. So you're not as strict, but you still actively encourage people to seek these services. And and at what stage then you kick them off the program if they don't show up? Then I think that's a design decision that you need to take. But thanks for that clarification. And yes, so the second result related to the visits, of course, is the proportion of women who received iron and folate supplementation in pregnancy, of course, because that was tied to these visits. But again, Carrie, if you want to come in and add results that are not listed here, because I didn't receive the detailed evaluation reports, etc., then you're most welcome. But we can also maybe push that actually to the discussion phase, which will happen very soon. Yeah. Good. Next slide. Okay, and here is, but that's, like I said, there's only one example from 2016 to 17 from ACF, where household cash and voucher assistance was given to children that were released from SAM treatment. The amount was 20,000 over the period of 6 months following discharge, and the objective was to address the underlying financial causes of child malnutrition and mitigate the risk of relapse. And there is a lessons learned report that actually Against Hunger has produced, and they were quite clear that they would not replicate the same approach. They applied continuous enrollment here as well, so people with SAM children could actually go to these treatment services and get enrolled into the program, So of course, then the word spread that if you have a SAM child and you go to the health clinic, then you can actually get enrolled into cash transfer program. So their lessons was to avoid using nutrition status as a targeting criteria, to systematically ensure independent verification of household eligibility, to determine contextually appropriate transfer amount. Here, of course, the transfer amount is an incentive. So the higher the transfer amount, the higher the incentive value of the cash. Yeah. So an amount that would purely be based maybe on transportation cost and maybe some other health-related costs related to accessing treatment services might actually not have the same incentive value. Yeah. But of course, is unlikely to fulfill the objective as it is stated here. And then to ensure sufficient internal controls, including monitoring accountability systems that are available for communities to share anonymous feedback. So that was the lessons from Action Against Hunger. I think other organizations have made similar experiences. The problem with the first, or not the problem, but the fact is that if you want to include a cash transfer as part of CMAM or of SAM treatment, then using nutrition status of children as a targeting criteria is unavoidable. So then the question is, okay, are you going to provide cash that has certain advantages and benefits, or are you going to leave it? Yeah. So that's really the decision that needs to be taken based on a risk assessment for that specific context. So based on these learnings, the organization then decided to switch towards a more not a protective but a preventative approach, actually, which then resulted in the IMP Plus, as we have seen before.
Can I just clarify? Sorry, I've had my hand up.
Yes, please.
I'm really sorry to interrupt. I think this is important, though. The IMP Plus was a second phase of the program, which came about due to sustained donor funding. So when that was confirmed, organizations separately and together revisited and perhaps revised their approaches. So it's just a small nuance there in the way you said that. So ACF decided to revise their approach into more of a protective approach, but that did not result in the IMP. The IMP happened and agencies made changes.
Okay, all right.
Okay, I also we have some concern as Green Code.
Yeah, please go ahead.
Yeah, looking at the lesson learned from Action Against Hunger, lesson number 1, to avoid using nutrition status as targeting criteria for cash voucher assistance. I don't know if there were further details to this, because for us in Green Code, we also do a CFA, but we use nutrition status as especially for critical SAM cases as part of the criteria. So when they are saying that one should avoid using nutrition status, so I wonder what they mean. And if anybody from Action Against Hunger is in the house, then they could throw more light so that we can also learn from this process.
Yeah.
Thank you.
I didn't hear anybody from ACF before, but let me just, so this is basically related to what I said before with the perverse incentive that can be caused by linking cash to the nutrition status of children. Because if you say, okay, if you have a SAM child and you come to the treatment center and then we enroll you in a cash intervention, you might contribute or you might incentivize families to make or keep a child malnourished because they want to have a SAM child in order so that they can access the assistance. And that is, of course, quite an important risk because from a do no harm perspective, that is, of course, very, very problematic. Again, here we need to understand the scope of the problem, which we don't, in many contexts, we don't understand. So is it 1 out of 100 children? where that has happened, or is it 30 out of 100? But it is a very problematic incentive that you are providing, and of course it's a bit similar with therapeutic food. So that can also be an incentive, actually, to keep or to make a child malnourished. And I think most nutritionists have maybe observed also in some contexts that in order to access therapeutic foods, some families take these measures. But therapeutic food, of course, is more considered as a medicine in that context, and cash would be more considered as a top-up or kind of a complement of the response. So it's certainly less essential in the treatment of the child. Did that help to clarify?
Yeah, it's okay, but I'm still wondering, if we don't use that, what other criteria can one use? So since we're on this platform, so it will be better we have a better understanding of the criteria one can use.
Yeah.
Especially in nutrition project.
Yeah. Now here we're talking specifically about treatment. We're not talking about prevention. We're talking about treatment of mainly SAM children. And if you are in a program that treats SAM children, your criteria is the nutrition status of the child. There's, in my mind, but other people can come in, there's no way around that. Now, of course, you can throw your cash net a bit wider and as part of safety nets, support all pregnant and lactating women in the area, and then you would not have that perverse incentive. But that, of course, is a very costly endeavor in itself, so not necessarily realistic in a humanitarian context without kind of a strong government system. So for the treatment, I think that's the main crux. And that's why I also said before, cash and vouchers for nutrition outcomes is more suited and has more potential for preventative strategies.
Andrew, would you like to contribute? Andrew?
Yes, this is Andrew, a nutrition specialist from Liberia. I just want to contribute on other probable targeting criteria. I think it's important for countries to be able to analyze the typology of undernutrition in their countries and identify which is the specific age cohorts that whereby you can make the most kind of progress. Like, for instance, if you look at many of the countries, you find that stunting increases highly or peaks at around 6 to 23 months when it's during the complementary feeding period. That could be a targeting criteria to improve the diet of children during the complementary feeding period by providing cash transfers or vouchers,
Please,
or
can
whatever.
you repeat yourself? We didn't hear you, please. Can you just repeat yourself?
Okay, sorry, maybe I'll go a little bit slower. I was saying that other probable targeting criteria could include probably an analysis of the typology of undernutrition in a certain country. I was giving an example whereby most countries, you find that stunting or undernutrition increases and peaks at around 6 to 23 months among children under fives. That could be a targeting criteria whereby you provide cash transfers or a social protection kind of support to households with these children so that they can improve the dietary diversity of the children. Another targeting criteria could be pregnant women, because we know that we also know that we have the 1,000 days whereby you have a window of opportunity whereby you can make a lot of progress in reducing undernutrition. So this could also be another targeting criteria. Lactating women as well could be another targeting criteria. I also agree with the observation from AH that in fact using nutritional status to target is not the best kind of
exactly. So what Andrew just also highlighted is, I mean, the interventions that he suggested, that's all preventative, because in preventative interventions, typically you don't rely on the nutritional status, but you rather rely on you know, the how do you say, like if a child is under the age of 2, if a child is under the age of 5, if the woman is pregnant or lactating, that's more related to, not necessarily related to the nutrition status. That's why, again, CVA has more potential and is far less problematic in preventative approaches. Any other additions or reflections on that? Otherwise, we come to the discussion for the part 2, so for Nigeria specific.
Hello, we have one more. Hola, Inca.
Thank you. You had actually answered what happened in the AAH program, but just in addition, for the people who are a bit confused, partly why they had to also remove using children, using the nutritional status of children as a main criteria was that we observed that most of the mothers kept coming back because they had to starve the children and to return back to the treatment so that they can receive the cash. So when they did a minor survey, they saw that that was happening among those who had been treated before. There was a relapse, mostly among them, and that was partly why they had to see it as a lesson learned and to improve. Secondly, I wanted to add to what Carrie said, partly why the program moved from what it was to a more multi-sectoral and pilot study was also to give the community the sense of early recovery, because we were thinking then that most of them were getting dependent on the cash, and we wanted to move towards prevention. So we're asked to redesign the project and focus on something that can lead to early recovery. And so you could see that the cash that was now being transferred was not so much, but more of what can help the families become sustainable, have sustainable livelihood was what was focused on. So it wasn't only on cash that was adjusted, but something else was introduced, which I think Andrea had also mentioned. So they had to introduce source of livelihood, not so that mothers and caregivers will not depend on cash. I want to just add again that some of the criteria, apart from looking at the younger age, could be to look at how mothers are, to put in cash towards discharge of a child from the treatment. So if the mother knows, as my babies or my children are getting discharged and getting better, I'm going to be supported, they will work towards supporting that child to recover quickly, and they will maintain the regimen for the treatment. And I think that will also help in prevention. So these were the issues around why IMP was redesigned and IMP Plus came around. It's something to help for sustainability. Thank you.
Okay.
Over.
Great, thanks for that. Yeah, I think sustainability, we could sit another 2 hours and talk about how to achieve sustainability. Of course, if you just give cash without any complementary measures, and if it's cash really focused on the cost of a diet or cost of basic needs, that is not by itself a sustainable approach, unless it's, you can hand it over to government-led safety nets, which have a longer time horizons and more predictability built into their systems. So then moving towards livelihood certainly makes sense where beneficiaries are capable of moving in that direction. Absolutely. Okay, I think the first question, correct representation, we already received some clarifications, which is great. in regards to some of these projects. If you are doing projects that have not been represented in that presentation, please feel free also to come forward and talk about your experiences, including challenges, lessons learned, and maybe also where do you see opportunities to use more CVA as part of a nutritional response in Nigeria? So that's just a couple of questions I've listed here, but I'm going to open up the floor now to anybody who wants to share something.
Thank you, Andre. Maybe Yadika, you have something to share?
Good afternoon, all. Yes. So, okay, yeah. I just wanted also to highlight also some of the additional lessons which are not also captured here, especially in relation gender dynamics at household level, because cash assistance to some extent have in other ways, change the dynamics in which women are perceived at both household level and community level. Yeah, to some extent, women are able also, because of the cash assistance being that they're able to contribute to, education at household level, and similarly at community level. Now, in other scenarios, also where it also leads to some sorts of gender-based violence, where men feel and then decide to start taking some negative actions on women. Yeah. So I think cash in this context can also have impact on gender relations, both at household and community level.
Great. So can have positive, can also have negative impacts on.
Yes, Lexington.
Okay, thank you. I will just give some lessons, not necessarily from Nigeria, but from the Zimbabwean experience that I once had or that I have. One of the key factors that we discovered when we're doing nutrition projects really were the fact that men are left behind. And that has a huge implication on the success of nutrition projects. I see there's a tendency to target the women and to target the children, and men are left behind. So what we then did was, as part of the conditions, was that the fathers to the children had to be part of some community committees, like the community kitchens, so that they also take a leading hand in child nutrition. So for us, it was a more sustainable model in that the men became active participants, not passive participants in the fight against malnutrition in children, and also in pregnant and lactating women. So my point has been, I think in our programming, we may want to really factor in and see ways we can bring men on board and they become active participants together with their women. Thank you. Over.
Thank you, Lexington. Adam.
I just wanted to make an input based on what the last Lexington said, that actually we have come to realize that, and men are being mainstreamed now into IYCF activities, such as forming support groups And for us, like us in Green Concern for Development, Green Code, we also realize the fact that we have, based on the religion and the faith, we have a lot of male religious leaders here, and they command a lot of influence. So in our nutrition project, we try to organize trainings for them to also understand the impact of malnutrition in their community, and also to let them understand that they also have a key role to play. So these are the two components that we're trying to bring men into this process, and they are also working very well. Even in terms of community nutrition mobilizers, we have also recruited some men, screening and also counseling. So it's helping. So, but I don't know how we can further increase this. Thank you.
Can I come in here?
Yes, go ahead.
Yeah, no, just I think these are really valid points that are being raised. They are not related to CVA and nutrition. They are more related to nutrition programming in general, I think. So I would ask if anybody has also more specific comments in regards to nutrition and CVA. That would be great. Thank you. If not, I will continue with cash transfers in Nigeria. Is that okay, Simon? Or
yeah, please go ahead.
Okay. So what we were talking about before is, you know, the projects that that use cash and voucher component as part of a broader nutrition response. Now here, this is more about cash transfers, so mostly basic need cash transfers in Nigeria. And you can see that it has increased quite significantly since 2016 in terms of financial requirements, and is quite a big part of the 2020 appeal. That is not only multi-purpose cash, but I believe multi-purpose cash is quite a big component, and most of it also sits, of course, within the usual suspects. So food security, livelihood is certainly the most important sector in terms of where that cash and voucher sits sectorally. As you might know, the motto, yes, I think most people should be clear what multi-purpose cash is. It's basically an amount that is calculated based on a minimum expenditure basket that represents needs across sectors. Yeah, so it really goes beyond food. It looks at the different expenditures that families have in order to survive or to address their basic needs. MPC was harmonized as part of a collaborative model in the Northeast, and the MEB, as it stands today, contains different categories, including food, of course, condiments and supplements, cooking fuel, water, laundry soap, bathing soap, sanitary pads, transportation, communication. I think there's even a health component in there. Now, when we think about minimum expenditure baskets from a nutrition perspective, there's, I think, two things that are important. First of all, the food basket, so the food component of the minimum expenditure basket, should provide the micronutrient requirements of average households, or even more precisely of at-risk groups within the households. Usually MEBs are given based on average household numbers, but of course you could be more precise in looking at, first of all, household size, but also household composition. Yeah. Of course, makes your life more difficult, but it's not impossible. Now, the second component or the second element is actually, especially where you identify economic barriers to accessing preventative or treatment, preventative services or treatment of malnutrition, then ideally the MEB would also take into account expenditures that facilitate access related to transportation, out-of-pocket expenditures, etc. Now, what I did is I took the MEB food basket and I put it into the NUTVAL to just make a very quick calculation on how the food basket matches the macro and micronutrient requirements of an average population. And this is the outcome. Now, I have to say here, I didn't, because the MEP doesn't provide very clear specifications on the food. So it's often, it talks about fruits or it talks about vegetable, and then it doesn't necessarily go into the level of detail, or it says salt, but it doesn't mention whether the salt is iodized or it's not. So it's sometimes a bit difficult to make that calculation just based on the MEP without digging a little bit deeper. But you can see here that that the energy requirements are met, the fat requirements are met, but most of the other things actually are not met. So most of the vitamins and micronutrients are not met by the foods that are contained in the MEP calculation. So there's definitely scope there to look at that with a nutrition lens, with a specialist support, to see, how that could be maybe expanded a little bit. What kind of food should be included to address some of these gaps? Yeah, because that could then at the later stage also inform communication strategies that could be around behavioral change communication that could be provided alongside NPC. But I think we're still a few steps behind such plans. Yeah. Which maybe brings me to the recommendations. And maybe we start with the nutrition cluster. Yeah. So I think what would be great is because Nigeria has a lot of cash experience, has a lot of interesting experience of using cash and vouchers also as part of the nutrition program. So it'd be great to see the nutrition cluster engage more on the documentation of these emerging experiences and learning, because there's just a lack of documentation and learning on that topic. The guidance note that I'm working on and will be released fairly soon tries to do that at the global level, but there's certainly a lot of scope for more country-specific exploration of this. Second thing, and that I think has already been planned in the past, but because of other priorities, and now certainly because of COVID, hasn't been on top of everybody's agenda. But to set up kind of an exchange forum between the nutrition cluster and the cash working group to discuss various aspects, including reporting, learning, and dissemination. In opportunities to integrate CVA modalities in the nutrition sector, but also opportunities to improve the nutrition sensitivity of multi-purpose cash. And here I particularly I'm thinking about complementing multi-purpose cash with some form of behavioral change communication, because that has really been seen as an add-on to household level cash assistance that can make a positive contribution to nutrition outcomes. And in contexts like Nigeria in the Northeast, where you have a lot of where you have high levels of malnutrition in almost all areas, it certainly could make sense. And how that could be best achieved, I think, is something to be further explored. Yeah. And of course, MEB and transfer amounts. I just mentioned the kind of the extent to which the MEB is able to cover average population macro and micronutrient requirements. So there's definitely scope for discussion there as well. Then to the cash working group, it's vice versa here, obviously. So same goes for the regular exchange forum. I think consult the nutrition cluster alongside the food security cluster, obviously, on discussions around MEB and transfer value calculation for NPC for the food component primarily, and also advise as required nutrition partners on technical aspects of CVA and market assessment. I think markets is something important to be looked at before engaging in providing cash and vouchers to improve dietary diversity, to improve access to nutritious foods, and nutrition actors might not have the right tools and experiences to do that. So there's certainly there room for collaboration as well. And to nutrition partners, really, I'm thinking here about, you know, the Action Against Hungers and the consortium that did the INP Plus, etc., to really invest also in documenting and disseminating learning. There is some learning products out there, some evaluations out there, but I think this is certainly something that could make an important contribution to the knowledge base of how we can integrate cash and vouchers in nutrition responses. So these are my my recommendations. Maybe I'm just going to finish with this, because now I think any topic or anything we present, I think, has to end on some reflections on COVID-19. That's just a couple of points from my side, which you might or might not have already considered. So COVID-19 obviously has an impact on food market systems, and I didn't check whether this has been looked at in Nigeria, but it could be, it could really prevent the use of cash and vouchers to access a nutritious diets, because nutritious foods is less available, maybe the prices are already starting to rise, etc. So this is something to look out for. At the same time, this pandemic might actually also impact the availability of nutritious or of specialized nutritious foods. So the whole supply chains of these foods that usually are not locally produced, so they need to be imported, etc. And of course, if you face a situation where you face supply breaks in some of these products, then you might have to think about switching to CVA temporarily in order to compensate for that. So this is something I think important to look out for. So the anticipated changes to market systems of local nutrition-dense foods, as well as the supply chains for specialized nutritious foods, and certainly the food security people and cluster, as well as the cash working group, are the right bodies to have these discussions with. Then of course there's the whole notion of how, if we do CVA in times of COVID, how can we reduce the risk of transmission? And there is a lot of guidance out there that that was summarized by CULP, and then I provided here the link if you're interested to click on that once you receive the presentation. But there's also different organizations have shared measures that should be taken when distributing cash or vouchers in order to minimize that risk. And then the last one is really, but that's, I mean, it's a tricky one and another low-hanging fruit. But in most countries, including Nigeria, existing social safety nets are being expanded both horizontally, so to more people, and vertically, so increasing transfer amounts to the chronic poor, or that's actually specifically for Nigeria. The National Social Safety Net Project, NASSP, has been expanded for existing chronic poor as well for transient poor. And I think there is also an opportunity to reflect, okay, how can we make sure that these transfers have a maximized impact, positive impact on the nutrition of women and children. But that conversation would need to be held with the authorities, so with the relevant ministries, but maybe already the cash working group has established these contacts. So this is something to maybe consider as well in the medium term. Of course, I'm very aware in regards to the recommendations that I have put forward before that COVID has changed the priorities of organizations. So this also has to be, taken into account in terms of, prioritizing the different actions. But I give the floor back to Simon to get feedback and provide reflections on this.
Thank you, Andre, for that. I would like to open up to any questions, any contributions to the floor, to everyone. Any feedback, please feel free to share. Thank you. I think there's one, Pauline had that question. I don't know that she's still online. Pauline?
Yes,
Yes.
Simon, good afternoon.
Good afternoon.
Okay, yes, I had a question that may be taking us a little bit back to some of the sessions, the earlier sessions. Okay, nice presentation, and I'm interested in the humanitarian intervention part of it. So I heard you mention about the BFP and ACF changing the model to using the criteria of pregnant and lactating women and targeting the first 1,000 years for implementation in the humanitarian sector. So I am quite conversant with this for development sector, and this is in relation to the fact that most of the time, mostly their fundings are for long-term fundings, 8 years, 5 years, and all. So I'm interested to know more about how that was carried out in the humanitarian sector. Was it a long-term funding as such? Was the enrollment done concurrently, or was it a one-off? I'm really interested to know how that will work here, or how that has worked here in the humanitarian sector. Thank you.
Pauline, thank you for your question. Is that directed to somebody in WFP, like maybe Carrie would like to respond to shed more light on that?
Thanks, Simon. I actually didn't get the entire question, but if I understood, it was to do with the enrollment of women and how long they stayed. Is that correct?
Yes, yes.
Okay. For
yes,
WFP,
and,
go ahead.
Okay, so it's for 1,000 days, targeting PLW for 1,000 days, and that is up to 2 years of that child. So I was asking, was this a one-off enrollment? Was it concurrent?
Okay, we lost you there, Pauline. Maybe, yeah. Carrie, I think she's asking if the pregnant and lactating was stayed in the program for those 1,000 days.
To support the 1,000 days, as were the agencies, and they were enrolled, what you're saying, concurrently. So if a woman was confirmed as pregnant, she was entitled to be enrolled into the program meeting other criteria, and that would continue up to the child's 2nd birthday. If a woman was breastfeeding at 2 months and met criteria, she would be enrolled into the program. So for WFP, there was a constant flow in and out. And this was problematic for a very short period, and certainly a key lesson for us, and we hope for the donor as well too, that this type of programming certainly requires much longer term funding, as you've mentioned. Over.
Okay, thank you.
Just Olainka, please go ahead.
Just in addition to what Carrie said, the donor had in mind of giving a longer term. Actually, the initial plan was IMP, it was for 3 years. But because of the challenges that started coming, the movement of the people and the redesign that came, everything had to change. So for an emergency, it's not so easy, I think, in my own understanding, to have that such of planned long-term plan, but donor in the beginning really wanted the 1,000 days, and that was why they had the funding for 3 years. But all the challenges that came into the program and all that led to the changes that happened.
Thank you, Inka. Yadika.
Okay. I just wanted to add to what colleagues highlighted, but also in responding to Colin. There's also the thinking of, now the humanitarian programs are being planned such that with a development thinking, such that humanitarian provides an opportunity for setting the pace for long-term development. So now, the IMP Plus, when it's been redesigned, it also look into more of an early recovery approach, such that, of course, yes, it's a humanitarian setting, but how do we set pace, help people shift out of, move out of complete dependence on humanitarian assistance to be able to start building resilience. And that was why, if you notice that when we're shifting to IMP Plus, some of the other locations that were selected for the project, although have been impacted by the humanitarian crisis, but then a little bit ripe for early recovery activities as well as development. So it was actually factored in it, and these are also some of the things that could be considered in providing humanitarian response where there's opportunity for that.
Thank you, Charles. Andre, would you like to respond to that?
Yeah, sure. No, I think that's actually a really important point raised, and I think with there's a growing recognition that in many of these protracted situations we have to look beyond the 1-year planning cycle that usually the humanitarian organizations follow. At the same time, I think the donors haven't quite found the right kind of the right modalities to support long-term humanitarian programming. I think particularly when it comes to responding to nutrition needs, I think the 1,000 days have proven to be an effective approach to certainly to prevent chronic as well as acute malnutrition. And I think, yeah, up to different actors now to try to maybe move more in that direction, or maybe improve collaboration with development actors. There's different ways to go about that, but there's definitely a need for better or for longer-term planning in humanitarian settings to address challenges such as nutrition.
Thank you, Andre. For the sake of time, if there's no really urgent issues or question, we can bring this to a close. I would really like to thank Andre for supporting the sector, for putting this together. I think it was quite useful. It has clarified a lot of the questions that many of the partners had about the CVA, issues of targeting, and which is the best program to use the CVA, which is the best approach. And I would really like to thank you for that. It was not difficult.
No problem.
It was not the most ideal. I know we were looking forward for you to come in to Nigeria, but unfortunately that did not take place. Maybe in the future, as you said, as a sector, we need to do more, but also of course, that will come with the support from the partners. I would like to thank all the partners that contributed to the success of this, ICRC, WFP, UNICEF, all the IAP partners. I know also IMC and Mercy Corps and Green Code were also involved. I would encourage them again to, there's still, as we say, there's still room to share their lessons learned. So I'm encouraging all of them to do that, so that we can have a wider perspective and more lessons from Northeast Nigeria. So thank you, everyone. Thank you, Cash Working Group, for supporting the sector on this. We will be sharing, I know, and Andre will be confirmed, will be sharing the final report with some revision and additional input.
Sure, yeah.
Yeah.
If you have any additional inputs, I'm talking to the partners, please. You saw my email on the first slide, so please get in touch. Otherwise, I will revise based on some of the feedback I received in this call.
All right, thank you. So, but I'm still encouraging everyone to look again at the document. I will reshare, and we will also be sharing this presentation together with this recording to all for those who missed out, and also for your own reference. So, thank you, everyone.
Thanks a lot. All the best. Bye-bye.
Thank you.
Thank you, and bye-bye.
Thank you very much.